Welcome, everyone. Today we're diving into bipolar and related disorders. This is really essential stuff for anyone heading into nursing.
Absolutely. It's a complex area, these mood variations.
Yeah, and our goal today is to really boil it down. What do you, as a future nurse, absolutely need to grasp for effective practice?
hmm We've got notes here covering bipolar and related disorders, and we're aiming to pull out the key insights.
We're focusing on the pathophysiology, the signs, the symptoms, and then the nursing care interventions, treatments. That's the mission.
Exactly. Mood disorders can feel a bit overwhelming at first, but breaking down, the core issues, what's happening biologically, what you see, it's vital.
And translating that directly into what you do, practical care.
Right. Interventions, treatments you'll be involved with, it all connects.
Okay, let's start with a really fundamental piece.
Yeah.
Eumania. When we say a patient is experiencing mania, what does that actually mean at its core?
Okay, so mania, fundamentally, it's a major disruption in how mood is regulated. Think of a mood that's elevated, maybe expansive, like this boundless optimism.
Or sometimes just really irritable, right?
Exactly, or intensely irritable. And this mood shift comes with a definite increase in their activity, their energy levels. It's not just, feeling happy.
It's a whole different state of being almost.
Precisely. It's a fundamental shift from their baseline. And it shows up with a cluster of key features that signal this dysregulation.
Like what? What are the big ones we should look for?
Well, grandiosity is a major one. And this isn't just being confident. It's an inflated, often totally unrealistic belief in their own importance or abilities.
Okay.
Then there's hyperactivity. It can seem relentless, physically and mentally. And pressured speech, you'll notice they talk really fast, hardly pausing.
They can't get the words out fast enough.
Yeah, like there's this urgent need to unload everything at once. Racing thoughts are another big sign. Their mind feels like trying to follow 100 different conversations at the same time.
Wow, that sounds exhausting.
It is. And it leads to distractibility. They just can't stay focused. Impulsivity is another crucial one to watch for.
Because that leads to risky stuff.
Yes, poor judgment, engaging in behaviors with potentially serious consequences, spending sprees, risky sexual encounters, rash decisions, and, very commonly, a dramatically decreased need for sleep. They might sleep very little, but feel completely wired.
Okay, so intense energy, but chaotic and potentially dangerous. Now, bipolar means two poles, right? These shifts between states. Can we break down the different types?
Absolutely. Let's start with bipolar I disorder. The defining feature here is having experienced at least one full manic episode. That's the diagnostic linchpin.
Or full manic episode. Got it.
Right. They might also have major depressive episodes, but that's not strictly required for the bipolar I diagnosis. And importantly, during that mania, they might experience psychosis.
Like losing touch with reality.
Exactly. Or they might need hospitalization because they're a danger to themselves or others, or just severely impaired in their daily life.
Okay, so bipolar I equals severe mania. How's bipolar 2 different then?
Bipolar 2 has a different pattern. Here you see one or more major depressive episodes, those periods of deep sadness, loss of interest, fatigue, all that, plus at least one hypomanic episode.
Hypomanic.
Mm.
So less intense mania.
Precisely. That's the key difference. Hypomania has similar symptoms, elevated mood, more energy, but they're less severe. Crucially, they don't cause that marked impairment in functioning or typically require hospitalization like full mania does.
So the up phase isn't as extreme in bipolar 2? That makes sense. What about cyclothymic disorder?
Cyclothymic disorder is, think of it as more chronic but milder. People experience numerous periods with hypomanic symptoms and depressive symptoms, but they never quite meet the full criteria for a hypomanic or major depressive episode.
So ups and downs, but not hitting the full peaks and valleys.
Exactly. And this pattern has to go on for at least 2 years in adults, or 1 year if it's a child or adolescent. It's like a persistent lower-level fluctuation.
Okay. And then there were those other types mentioned induced by substances or medical conditions.
Right. Important distinctions. Substance medication-induced bipolar disorder is when the mood disturbance, manic-like or depressive features, is clearly a direct physiological result of using a substance or withdrawing from one.
Like cocaine. Or steroids even.
Yes, exactly. Cocaine, amphetamines, steroids are common examples. The key is that direct link. Then there's bipolar disorder due to another medical condition.
Such as
Things like thyroid problems, MS, maybe a stroke, or a traumatic brain injury. The mood symptoms are seen as a direct consequence of the underlying medical issue. Sometimes, treating that condition helps the bipolar symptoms.
good to keep those other potential causes in mind. Okay, let's talk numbers. How common are these disorders? What's the epidemiology look like?
Well, the lifetime prevalence in U.S. adults is estimated around 4.4%, so not insignificant.
And does it affect men and women differently?
Interestingly, it's pretty evenly distributed between genders. The typical age of onset, when symptoms usually first appear, is around 25.
Mid-20s. Okay.
And something really critical for us, especially in nursing, is the high suicide risk associated with bipolar disorders. It's significantly elevated compared to the general population.
That's a really sobering statistic. It definitely highlights why effective care is so vital.
Absolutely. Early detection, accurate diagnosis, ongoing management, they're lifesavers.
So let's dig into the why. What do we think causes bipolar disorders? The etiology.
It's definitely complex, understood as multifactorial. Biology plays a big part. Genetics, for instance, having a family history is a major risk factor.
So runs in families.
It strongly suggests a genetic predisposition, yes. Then, biochemically, there's a lot of focus on neurotransmitters chemicals like norepinephrine, serotonin, dopamine. The idea is that there's dysregulation in these systems involved in mood.
An imbalance, basically.
Kind of. And some studies even show subtle differences in brain structure, neuroanatomical differences in people with bipolar disorder.
Okay, so biological factors are key. What about psychological or social influences?
Those matter too. Things like childhood trauma have been linked to increased vulnerability later on, and stressful life events. They often act as triggers for mood episodes, especially in someone who already has that biological vulnerability.
So stress can set it off.
In someone predisposed, yes. There's something called the transactional model, which tries to capture this interplay. It suggests bipolar disorder emerges from this mix of genetic or biological vulnerability interacting with environmental stuff, like stress. It's rarely just one thing.
A combination of nature and nurture, essentially.
You could put it that way, yeah.
Now, how might these symptoms look different in kids or teenagers? That seems like it could be tricky to spot.
It really can be. That's a super important point for nurses working with younger people. The presentation can be complex, and sometimes it looks a lot like other conditions, especially ADHD.
ADHD.
How so? Well, symptoms like irritability, being easily distracted, hyperactivity, those can overlap quite a bit between bipolar disorder and ADHD in kids.
So you can mistake one for the other.
Or, importantly, they can co-occur. It's not uncommon for a child or adolescent to actually have both bipolar disorder and ADHD.
Wow. So how do you approach treatment then?
That's a key clinical point. If both are present, the general recommendation is to stabilize the mood first. So start treatment with mood stabilizers before introducing stimulant medications for the ADHD.
Why is that?
Because stimulants, while helpful for ADHD, could potentially worsen manic symptoms or even trigger a manic episode in someone with underlying bipolar disorder. Mood stability comes first.
That makes sense. Prioritize the mood.
Exactly. And it's also worth mentioning DMDD, disruptive mood dysregulation disorder. That's a relatively newer diagnosis in the DSM-5.
What's that for?
It helps differentiate kids who have persistent severe irritability and frequent temper outbursts from those with the more distinct episodic mood swings you see in classic bipolar disorder. It clarifies the picture a bit for diagnosis in youth.
Okay, helpful distinction. Let's get really specific now about the mood states. You mentioned mania, hypomania. Can we break down the stages? Like stage 1, 2, 3, how does it progress? Recognizing these is crucial for assessment, right?
Absolutely crucial. Okay, stage 1, hypomania. We touched on this. It's the less severe form. You'll see someone who's noticeably cheerful, maybe overly optimistic, definitely has inflated self-esteem.
Our energy.
Definitely increased energy and activity. Their thinking might seem quick, jumping between ideas flighty. They get distracted easily. Libido might be up. Socially, they might seem very outgoing, extroverted.
But maybe not connecting deeply.
Exactly. Lacking depth in relationships sometimes. The key thing in hypomania is that their overall functioning usually isn't drastically impaired. They might still go to work, manage some responsibilities. Hospitalization isn't typically needed here.
Okay, that's hypomania.
Yes.
What signals the shift into stage 2, acute mania?
Acute mania is where things intensify significantly and really start interfering with life. That euphoria might still be there, but it's often more unstable, mixed with a lot more irritability.
And this is where psychosis might appear.
Yes. Delusions, those fixed false beliefs, can emerge. Sometimes hallucinations too, seeing or hearing things that aren't there. You'll likely see marked psychomotor agitation, restlessness, pacing, can't sit still.
And the impulsivity gets worse.
Much worse. Poor judgment is really common. Risky behaviors, financial recklessness, inappropriate social conduct. This is the stage where hospitalization becomes necessary often to keep them safe and get things stabilized.
Right. And stage 3, delirious mania, you said it's rarer now.
Thankfully, yes, much rarer due to better and earlier treatments, but it's important to know about. It's an extremely severe state, potentially life-threatening.
What does it look like?
Profound disorientation. Severe psychosis delusions, hallucinations are common. Extreme agitation, but also potentially leading to physical exhaustion. It's a medical emergency, really, needing intensive intervention.
Understanding these stages really helps frame what we might observe. So how do we, as nurses, translate these observations, these behaviors, into nursing diagnoses to guide our care?
Great question. It's about connecting the dots. So if you see that intense hyperactivity, the agitation, the pacing, that points directly to a risk for injury, both to themselves and potentially others if the agitation is severe.
Okay. And the delusions or impulsivity?
That brings up risk for violence, self-directed or other-directed, depending on the content of the delusions and the nature of the impulsivity. If they're not eating or drinking because they're too manic, losing weight, that's imbalanced nutrition, less than body requirements.
Makes sense. What about the thought disturbances?
If they're experiencing delusions or hallucinations, your diagnoses would be disturbed thought processes or disturbed sensory perception. If you observe manipulative behavior or they're struggling to form connections, that points to impaired social interaction.
And the lack of sleep.
That's clearly insomnia. Each observable symptom cluster helps you identify the priority problems to address in your care plan.
So based on those diagnoses, what are the key nursing interventions? What do we do?
Interventions flow directly from the diagnoses and always prioritize safety. For that, risk for injury patient. Maintaining a low-stimulus environment is huge. Less noise, fewer people, calm interactions can help decrease agitation.
And constant observation.
Close monitoring, absolutely. Frequent checks for any signs of self-harm or escalating aggression. You'd also remove potentially dangerous objects from their immediate environment, sharps, belts, cords, things like that. Safety first.
What about nutrition?
Encourage rest periods. Offer fluids frequently. Provide high-calorie, high-protein foods and drinks that are easy to consume on the go, since they might not sit still for a full meal. Finger foods are often a good strategy.
And for the disturbed thoughts or perceptions?
Focus on reality orientation, but gently. You don't argue with delusions, usually, but you can calmly reinforce what's real. I understand you believe that, but I don't see anyone else here. Maintain a safe, structured environment. Consistency is key.
What about the social interaction issues?
Setting clear, firm, consistent limits on any manipulative or intrusive behaviors is important. But also, when they're able, encourage appropriate social interactions. Positive reinforcement for pro-social behavior helps.
And sleep?
Promote a regular routine as much as possible, even amidst the mania. Encourage rest periods during the day. Ensure a quiet, dark environment for sleep at night. Discourage caffeine, especially later in the day.
And across all of this, education must be key, right, for the patient and family.
Absolutely vital. Educating the patient when they're receptive and the family about the illness, about the medications, about recognizing triggers and early warning signs. Involving the family is crucial for support and adherence.
Okay, that gives a great framework for nursing care. Let's shift to the medications. Pharmacology is a huge part of managing bipolar disorder. What are the main categories we need to know?
Medications are definitely a cornerstone. The main players are the mood stabilizers. These aim to control manic and depressive episodes and prevent future ones. The classic example is lithium.
Lithium. I know the one needs careful monitoring.
Extremely careful. It has what we call a narrow therapeutic index. The effective dose is close to the toxic dose, so regular blood level monitoring is non-negotiable. The typical therapeutic range is about 0.6 to 1.2 millieql.
And nurses need to know the signs of toxicity, right?
Absolutely. You have to teach patients and families this too. Early signs can be things like fine hand tremors, nausea, vomiting, diarrhea, maybe some muscle weakness or lethargy. As levels rise, you see confusion, coarser tremors, slurred speech, and in severe toxicity, seizures, coma, even death. It's serious.
Vigilance is key with lithium. What other mood stabilizers are common?
Another major group are the anticonvulsants that have mood-stabilizing properties. You'll see valproate or valproic acid, brand name Depakote quite often. Also carbamazepine or Tegretol, and lamotrigine, Lamictal.
Do they work the same way as lithium?
Different mechanisms, and they have their own side effect profiles and monitoring needs. For example, valproate and carbamazepine need liver function tests and blood counts sometimes. Lamotrigine has that rare but serious risk of Stevens-Johnson syndrome, a severe rash, so patients need education on watching for that.
Okay. And calcium channel blockers were mentioned.
Yeah, they've been looked at, things like verapamil, but they're not really first line. More experimental or used if other options haven't worked or aren't tolerated.
What about antipsychotics? Where do they fit in?
Atypical antipsychotics play a big role, especially for acute mania. Meds like olanzapine, Zyprexa, risperidone, Risperdal, quetiapine, Seroquel, aripiprazole, Abilify. They can help bring down agitation, psychosis, and racing thoughts relatively quickly.
So for getting acute symptoms under control.
Yes, often used initially for that, and sometimes continued alongside a mood stabilizer for longer-term maintenance, particularly if psychosis was present or if the mood stabilizer alone isn't fully effective.
And antidepressants. I thought those could be risky in bipolar disorder.
They can be. That's a critical point. Using an antidepressant alone in someone with bipolar disorder carries a significant risk of triggering a switch into mania or hypomania or inducing rapid cycling.
So you don't use them.
You use them very cautiously, primarily for significant depressive episodes, and almost always in combination with a mood stabilizer or an atypical antipsychotic with mood stabilizing properties. The mood stabilizer acts like a ceiling to hopefully prevent that manic switch.
Good to know. Always with a mood stabilizer. What about light therapy?
Bright light therapy, or BLT, there's some evidence it can be helpful for bipolar depression, particularly the seasonal pattern type. And a potential advantage is it seems to have a lower risk of causing that switch into mania compared to antidepressant meds.
Interesting alternative for depression.
Yeah.
Okay, we've covered meds. You mentioned education earlier, but let's focus on that specifically. What are the absolute must-teach points for patients and families?
Education is empowerment, truly. First, they need to understand the illness itself, that it's a medical condition, it's cyclical, it's not their fault. Reducing stigma is huge.
What else?
They need to know the symptoms, both manic and depressive symptoms. Recognizing early warning signs of an impending episode allows for early intervention, which can often lessen the severity or duration.
And medication teaching.
Paramount. Name, dose, frequency, why they're taking it. The absolute importance of adherence, not stopping meds abruptly, even when feeling well, because that's a major trigger for relapse. Potential side effects and who to call if they occur.
And specifically for lithium.
Reinforce those signs of toxicity again and again. And stress the need for those regular blood tests. Non-negotiable.
Lifestyle factors, too.
Definitely. The importance of a regular sleep-wake cycle, social rhythm therapy builds on this. Avoiding alcohol and illicit drugs as they can destabilize mood and interfere with medications. Stress management techniques, finding healthy ways to cope with stress.
And where to get help.
Absolutely. Make sure they know about resources, crisis lines, local NAMI chapters, or other support groups for both the patient and family members. The benefits of ongoing therapy. Connecting them with support is key.
It's a whole package deal. Meds, education, lifestyle, support. What about other formal treatments besides meds and education? Therapy.
Yes, psychotherapy is a really important adjunct to medication. It's generally not considered sufficient as a standalone treatment for bipolar disorder, but it adds significant benefit when combined with meds.
Are there specific types that are helpful?
Several have good evidence. Cognitive behavioral therapy, CBT, helps patients identify and change those negative thought patterns and behaviors associated with mood episodes. Family-focused therapy, FFT, is great because it educates the whole family, improves communication, and helps them solve problems together related to the illness.
That sounds really beneficial involving the family.
It really is. And then there's interpersonal and social rhythm therapy, IPSRT. This one specifically focuses on helping patients regulate their daily routines, sleep, meals, social activity, because disruptions in these rhythms are known triggers. It helps stabilize those biological and social clocks.
So therapy helps with coping, routines, family dynamics, all supporting the medication.
Exactly. It enhances coping skills, improves adherence, helps manage stressors, and reduces relapse risk.
And what about ECT, electroconvulsive therapy? When is that used?
ECT can be a very effective, sometimes life-saving treatment. It's typically reserved for specific situations like severe treatment-resistant mania or depression, particularly when there's acute suicidal ideation or psychosis, or if the person's physical health is rapidly declining due to the mood episode, like not eating or drinking in severe mania or depression. It can also be an option when medications aren't tolerated or are medically contraindicated, like sometimes during pregnancy.
So it's for more extreme or unresponsive cases.
Generally, yes. It often works much faster than medications for acute episodes.
Okay. Wow, we've covered a lot of ground here. This has been a really thorough deep dive into bipolar and related disorders. Super valuable for nursing students.
Agreed. We've gone through the types, the potential causes, how it looks in different stages and ages.
The critical nursing diagnoses and interventions, the different medication classes and their nuances.
Plus, the vital role of education and other therapies like psychotherapy and ECT.
Understanding all these facets, the biology, the psychology, the social aspects, the treatments, it's all essential for providing good nursing care.
It really is. As nurses, you're right there on the front lines. You're monitoring, you're administering meds, you're teaching, you're providing that safe, supportive environment. Your observations, your understanding of why certain treatments are chosen, your therapeutic communication, it all makes a huge difference.
So thinking about everything we've discussed, this intricate dance between biology, psychology, environment, what do you think are the biggest challenges, but also maybe the biggest opportunities for nurses aiming for truly holistic care for these individuals? Something to really mull over as you move forward.
That's a great question to end on. Balancing symptom management with promoting long-term wellness and recovery, it's complex but incredibly rewarding work.
Definitely something to think about. Thanks so much for joining us on this deep dive today.